Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual. And today I'd like to have a discussion with one of the most important subspecialists that I interact with every day, the Pediatric Hospitalists. Pediatric Hospitalists serve as an extension of the Pediatric Emergency Department. They accept our patients for admission and do their very best to take care of them from that point on. They often are used as the diagnosticians when we have no idea what the patient has. That is why I invited Jason, a pediatric hospitalist at Colorado Children's, to talk about the relationship between the pediatric hospitalist and the pediatric emergency physician. Thank you, Jason, very, very much for coming on the show. Good morning to you. Let me just introduce you to the listeners of PEM Rules. Jason is originally from Syracuse, New York. He received his medical degree at SUNY Upstate Medical University in 2001, and then completed his pediatric residency and chief residency at University of California, San Francisco, UCSF in 2005. And then he remained there as faculty in addition to being the assistant program director and transport director of Pediatric Hospitalist Medicine in California, Pacific Medical Center. And then in 2010, please correct me if I'm wrong, Jason, you took a position as a pediatric hospitalist at the Children's Hospital of Colorado in Denver, which is a great children's hospital. And you've been there ever since. Is that right?
Exactly right. 100%.
All right. And in addition, you have a lot of other roles. You're currently the Target Zero safety coach at this institution at Colorado Children's. And also the medical director of the APP program fellowship that you have. Is that right?
Yep. And one of my new things I'm doing now is we have a new surgical co-management team. And I'm the medical director of our surgical co-management team where kids of extreme medical complexity, post-operatively, they get admitted to my service. And then we co-manage the patients with the surgeons. And it's a great thing so far.
Very interesting. So you clearly have great interest in taking care of exceptionally sick kids, which is great because we definitely need the help. And let me start by asking you a question, Jason. It's a question I ask all my guests on PEM Rules. What is your definition of a good PEM physician? One who does what?
Great question. Multifaceted. For me as a pediatric hospitalist, I obviously want them to have the knowledge base of knowing sick versus non-sick, stabilizing very, very sick children, and then beginning the diagnostic evaluation and management for children in the emergency room. I'd say the number one, above and beyond that, though, what separates the good from the great is communication skills. And what I mean by that is a collaborative effort where you who are starting the initial workup, diagnostic evaluation and management down in the emergency room, and then knowing a patient's going to get admitted, we can work symbiotically to give ideal care to the patient once they hit the floor. There's several examples of what you guys do down in the emergency room sets us up for success or failure upstairs. And what I mean by that is twofold. One, the medicine. By the medicine, I mean, let's use an example of a febrile neonate, okay? So a baby comes in and has a fever and is 3 weeks old or whatever, and there's new guidelines for exactly what you need to do for that child. And greater than 21 days of life now, it varies, right? So call me if the child is 21 days and 8 hours and let's have a conversation saying, Jason, I'm going to go full court press and get the lumbar puncture in addition to the urine and blood culture and start empiric antibiotics, or this baby looks very well. RSV is positive on the RPP. I'm going to hold off on antibiotics right now and defer the lumbar puncture to you upstairs or something in between. I would say the situation we get in trouble is the febrile infant that you don't do the lumbar puncture on, but start empiric antibiotics, and then the kid gets sick, and then we have pre-treated cerebrospinal fluid. So that's just an example off the top of my head where please call me so we can collaborate together to give ideal care to the patient upstairs. And I'd say the second part, which is as important or more important, is the communication with families. Trying to lay out what's going to happen upstairs to set me up for success, explaining why you did or did not get the chest x-ray. And the correlative is why I'm not going to get it upstairs either. You are the physician and usually the first physician or provider downstairs. You are God to them, right? You are setting the expectations for everything that's going to happen moving forward. And if you paint the right road, for me, things 95.7% of the time go well. And if you give information that I'm not necessarily going to agree with, I got to dig myself out of the hole for the next day or the next week or the next month that the patient is admitted to. And if we have the conversation before you give that information, it's going to go well. And I would say communication. And look, communication is the key to life, right? It's the key for relationships. It's the key to friendships. I'm trying to communicate better with my 14-year-old daughter that's going on 27. It's the key to life. And I think it's the key, in my mind, of being a good PEM doc or PEM provider in terms of that transition to care from an inpatient standpoint.
Yeah, so those are really, really good point, Jason. And I'm glad you bring those up. One of my rules that I teach the residents, and I talk about it in PEM Rules, and I try to do it myself, is set up your consultants for success. So, very often primary cares send patients to the emergency room and they send them with what I call the script. Mom and dad, you're going to go to the emergency room and then you're going to get XYZ. And that sets me up for failure. I would much rather the primary care said, Mom and dad, you're going to go to the emergency room. Over there, there's a specialist. He'll take care of you. I'll trust him. And then by all means, every primary care is invited to call me and discuss, like you just said. I try to do the same thing for the hospitalist. Mom and dad, I'm not exactly sure what's going on with little Johnny today. I'm going to admit you to the hospital. Upstairs, there's a hospitalist who's a diagnostician. He's going to figure this out. You guys are in great hands. So I try to do that because I try to build other people for success, just like I want other people to do to me. So I appreciate what you said. And you spoke about communication. I could not agree more. One of the communication skills, and is one of the rules that I speak about, is don't tell people what you want, tell them what you need. So I think oftentimes when I speak to the hospitalist, I try to apply that rule. But I couldn't agree more. I think us PEM physicians, like you said, who are sort of the screeners in evaluating and checking the kid, just do the first few steps and then you guys take it over. And I totally appreciate the fact that sometimes the patient is in your department for days or weeks and it's for you to deal with. So thank you very much for saying those words. That's really great advice for us PEM clinicians.
Can I add one more thing, Yaron, while we're going? The three words that I unfortunately say too much at Children's Hospital Colorado is I don't know. We have 1,000-mile radius in terms of referral base. So we're getting diagnostic conundrums from everywhere in the Western region, the Midwest and the Southwest. And what I find myself, I joke, I have a very good APP that sometimes frowns at me and goes, Jay, I can't believe how often you say, I don't know. And I say it confidently. And so to just take that to the next level, if a PEM provider pigeonholes a diagnosis downstairs, that's what the parents are going to lean on. That's what it is. And then all of a sudden, if the game changes upstairs a little bit, it's that much more challenging. If it's acute appendicitis on ultrasound or on CT, it's acute appendicitis to some degree, right? But if it's a fever of unknown origin for 2 weeks, if you say that it's adenovirus and then it's not adenovirus, that makes it more challenging for us to work on upstairs. And I would say the same thing. You said it well. We're going to bring you up to whatever you called us. I thought that was well said, diagnostician, and say, but if you know what it is, great. But if you don't, it's better to say, I don't know, and we'll work it out down the line. Because I have to say, unfortunately, there are many children that I discharge from our hospital, and we still say, we know what it's not. We're much better in this day and age at 2023 saying what something is not. We are not as good at saying what something is. So I think setting us up for success in that realm is very helpful too.
No, I couldn't agree more. And with your permission, and I'll give you the credit, I'm going to use that as one of my rules. Say, I don't know. When appropriate, say, I don't know.
And say it confidently, because if you say it confidently, somehow it balances out. Yes.
No, I agree.
It's yours. Use it as you will.
Thank you very much. My other question to you, or sort of like a point of discussion, and this is something with my experience that I wanted to bring up. I often find my relationship with the hospitalist to be sometimes challenging because of the difference in approach. And let me explain. So as a PEM physician, I think I have the privilege of, and I teach that to the residents, I have to do two things on every patient. Number one, I have to provide acute care, be it CPR or maybe just Tylenol. And then I have to decide on the appropriate disposition. Is this fever, this belly pain, possibly something bad that I need to admit the child to the hospital, or can they safely go home? Somewhere in the middle, I may or may not do a workup, but I may or may not get a conclusion. And it doesn't happen very often that I really have no idea what the patient has, but every once in a while, I admit a patient to the pediatric hospitalist and I say, listen, I got those labs, this and this. I don't really know what the patient has. And I feel like some hospitalists may resent that and have some expectations that I know what's going on, or I have a diagnosis or a specific disease in mind. What do you think about that? And how do you go about resolving this?
Yeah, let's take a step back. Is there, I wouldn't call it conflict, but disagreement among styles and perspectives? Sure. But I always feel that it would be great to walk in the shoes of another discipline, right? I wish I could be a bedside nurse for a week. And then I wish the bedside nurses could carry all my pagers and you know what I mean? And live my life. The same thing. And the same thing applies for you. I wish I could be a PEM physician and deal with the stress of triaging and stabilizing and then having to making that decision of either sending home or sending upstairs. I wish I could have that. And I wish you could live a week in the life of my shoes, of the challenges of expectations upstairs, psychosocial, et cetera, et cetera. I don't think it's a matter, at least at our institution, of, Yaron, you're not getting the diagnosis right. Shame on you. I think it's more the amount of testing and resources being done downstairs. And like I said, not communicating such and setting us up not to fail upstairs, but sometimes not to succeed. A quick story. We have an excellent PEM fellowship at Children's, and we have excellent pediatric emergency medicine trained physicians downstairs in our ER. Rakesh is a good friend of mine, and he's a PEM. I think he did fellowship at CHOP, and he came here, and he gave a talk to us once, and he said, Jason, when I'm down in the emergency room, I expect two things. There's two gospel downstairs, and he was being off the cuff, but he said, one, I expect if I send a patient home, I will never see them again. And two, I expect all those patients that go home are going to die. And I think that was a little, a little grandiose, et cetera. But he made the point. It's a good point. We as hospital medicine physicians have the greatest diagnostic tool of all time. And that tool is time. We have the ability to assess and observe upstairs. And if a kid's getting better, or if a kid's not getting worse, if it ain't broke, don't fix it. If the child is getting worse, then we have to act and start from square one and expand our differential and do more diagnostic testing and do more management. You guys downstairs don't have that luxury, right? So because of that, you have to test more to ensure that B doesn't happen, i.e. a bad outcome when you send home. And I get that. And I thought that was very insightful. There are inherent differences in our professions. At the end of the day, we're just trying to make sick children better, but there's differences in the way that we have to approach that based on what we do. You know what I mean? So I'm being very long-winded right now. I don't think it's a matter of knowledge base or testing enough, I think it oftentimes for us is testing too much. Why are you getting the chest x-ray on that patient that I think has a viral process? Why are you getting the CT scan and exposing the child to radiation when we can do serial abdominal exams upstairs? Why are you sedating the patient for the MRI and putting the patient to sleep when we can get a neural consult upstairs and we can do Q2-hour neural checks and do it a little bit differently? And I think that's where the difference in philosophy comes in. And at times there's conflict. But again, if you pick up the phone and explain your rationale to me, 99 out of 100 times, I'm going to say, okay, that's a good idea. Let's do it.
That's great. So you basically just summarized very well and very wisely what I call PEM rule number 4, less is more. In most healthy, vaccinated kids, the less we do, the better. Yep. And I got to tell you, there's something very satisfying for me personally. One of the most satisfying things to do is to admit a patient for observation. Just like you said, I don't have it, but you have it, the gift of time, and see where this goes. And I love it when the hospitalist, specifically the surgeons, support me in admitting a child that I think has appendicitis. I really don't want to do the CT. If we can just admit him and see where this goes. If this appendicitis, he's in a good place, he's safe, and this will declare itself. I think we irradiate too many kids, we give too much antibiotics, and you guys are in the front line of avoiding that. And I love it when the hospitalists support us in doing that. And again, avoid antibiotics, avoid radiation, avoid excessive testing, and just see where this goes.
And I couldn't agree with your agreement and more. And what I would say is that the corollary, not to beat a dead horse, is if you pick up the phone and call the surgeon or call me and we have a discussion, then we're all on the same page, and it's golden.
Wonderful. Yeah. So those are really great points for PEM Rules listeners to hear. Jason, thank you very, very much for coming on the show. As usual, I'd like to honor you with an outro of your choice. And I guess you like Phil Collins and you wanted to hear In the Air Tonight.
I'm old school, so let's do it.
All right. That's a great song. I think that's one of my wife's favorite songs. And I got to tell you, I saw Phil Collins in Florida a few years ago. What a unique voice. What a unique artist. Unfortunately, he has some health problems. He was walking with the cane, but he's a true rock star.
To go back to my upstate roots, I saw him at Saratoga Performing Arts Center in upstate New York many, many moons ago. And that's where he had me with this song.
Nice. Oh, so that's a great song. Thanks again for coming on the show. Really, really appreciate it. And hopefully we can maybe do this again sometimes and improve the communication between PEM physicians and hospitalists.
It's my pleasure, Yaron. Thank you for the opportunity.
Thank you very much. And that is it for today, guys. Thank you very much for listening to PEM Rules. Thank you for submitting all your feedbacks and requests. Please feel free to check out EP Monthly for my column, as well as the PEM Rule website. Continue to communicate, and if you have anything you want to talk about, any patients you want to discuss, by all means, let me know. This is In the Air Tonight by Phil Collins, the best I can do. Hope you like it.